Thank you so much, sir, for your kind words. And I would like to thank AIOS and Dr. Himanshu, Dr. Rohan, and Dr. Pooja for giving me this opportunity. So, as told by sir, I will be taking up patient selection in FLACS, the most important step. So for me, there are a couple of things which are important for the patient selection. First of all, that the pupil should be adequately dilated. Preoperatively, we always analyze this. So my cutoff is 4.5 millimeter. And specifically patients on IFI, pseudoexfoliation, diabetes mellitus, history of uveitis and trauma, we check, and I always start NSAIDs 1 or 2 days before, so as to prevent any intraoperative meiosis. And then the other thing which I check in the patients is proper positioning. Have to check whether the patient is obese or if he has neck issues. Then I usually avoid such patients because they have problem in positioning under the machine. Anatomical factors like deep socket, narrow palpebral apertures, loose conjunctiva, we have to see that we have to be careful, as these are the reasons for suction loss during the femtosecond procedure. Then of course uncooperative patient, anxious patients, Parkinsonism patients with tremors, and that's why I spend some time for good preoperative counseling, so as to tell them, so as to check whether the patient is physically fit, good dilatation, and I explain them about the procedure so that they are prepared for the procedure. There are a couple of things where I don't do FLACS, like severe subluxations and small pupil. My cutoff is 4.5, but I've tried till 4.2 also, but I usually avoid below that. Then scarred corneas, as you can have misfired areas, then severe nystagmus, small palpebral apertures, severe conjunctivochalasis, of course small hyperopic eyes as there is difficulty in suction, and then when you have an uncooperative, physically unfit patients. But of course, my procedure of choice of FLACS are all these conditions like white and hypermature cataracts, as it gives you a very good opportunity of a fast capsulotomy. Then weak zonules, pseudoexfoliation, as there's a difficulty in doing rexes. Then you have traumatic cataracts. Dense and mature cataracts will be dealt later by Dr. Gaurav. Posterior polar will be dealt by Dr. Himanshu. And then, of course, cataracts with pre-existing PCA, especially patients who had previous anti-VEGF injection, as you get an advantage of an OCT in FLACS. And then small eyes, where, of course, with very low ACD, you get difficulty in doing capsular rexes and phacomorphic glaucomas. So let's talk about how I'm going to discuss few complex cases in FLACS, like how FLACS has an advantage in white cataract because you have fast completion of capsulotomy to prevent initial injection of fluid into AC once capsule breakthrough occurs. So you can do it titrated within 1 second, so that once the fluid comes out, before that the capsulotomy is completed. And then you have an advantage of a closed chamber. So this is a case of a hypermature Morgagnyan cataract, where you can see the lens thickness is just 3.2, which is, we have a small nucleus in that. And what I do here is I titrate my settings in capsulotomy to make it 1.1 second. It is done by you can decrease the diameter. I usually decrease it to 4.5 here. I've kept it 4.7. And then you can increase the vertical spot spacing. Normally it is kept at 10. So you increase it till 13. So that's how you reduce your time. So you can see here it is 1.1 seconds. So I'll just go through the procedure, how it is done, and how you can see here while I was doing the OCT, the FLACS OCT, there was a problem in the detection of the lens anterior surface and there was fitting errors. So what you do is you just rescan it, just check, and you'll see that because it is out of the normal range, the size of the nucleus is very small, so it gives you these fitting errors. So you manually adjust them according to the anatomical surface. So I'm doing the anterior surface of the lens, so you can do it. It is very easy. So that's how you do the anterior surface, and then the posterior surface is also matched with the posterior. So I've kept a 750 micron posterior capsule safety margin also in this because of the small nucleus. So iris mapping is also done manually. So once it is done, you can see, you can match all the anatomical surfaces very easily, and then I increase the vertical spot spacing for the capsulotomy so that to reduce the time to 1.1 seconds. And these are all my settings. I have increased the posterior capsule safety margin also, and then you press the button, and you'll see here that it is all matched, and you can see that the capsular rhexis is just for 1.1 second, and by the time the fluid comes out, the capsular rhexis is completed. So that's the main aim, because once the fluid interferes in the laser, you can have uncut areas. So you see here, there's a milky fluid in the anterior chamber. So you have to shift it immediately, like in half an hour's time. So always remember to do capsular staining in these technique. I use a 30 gauge needle under air technique. So with few drops, you are able to stain the capsule, because you know that you have these uncut areas, and if you don't stain, you can end up into an anterior capsular tear. So you can see that 70% of the capsule is free floating. So for the rest of the area, you just do a normal capsular rhexis in a circular guided way, and that's how you just complete it. So this was a hypermature Morgagnian cataract. As you know, the nucleus size was small, so I was having a difficulty in holding the nucleus while doing chopping. So what I strategically do is, in these cases, is I take the equatorial support of the bag by to immobilize the nucleus so that I can chop it easily. So you'll see here, what I do here is I immobilize the nucleus by taking the equatorial support of the bag and then doing a direct chop. So this makes it very easy to chop, as you know these pieces are very small. And you can also do an IOL scaffold before taking out the last piece, because in these cases you have vitreous syneresis, there is PC flutter, so you can do that also. So it becomes really easy, and the case is completed. We published this nucleus management technique last year as well. So coming to fibrotic cataract, again you have an advantage of closed chamber. So advantage of doing capsulotomy in fibrotic cataract is that it cuts the capsule over the fibrotic bands. So you can increase the laser energy, and incision depth can be increased because the anterior capsule thickness is more, and you can easily do capsulotomy and a nuclear fragmentation in fibrotic cataract. So again, under air, always remember to do capsular staining, because it's really important, as you can always end up into uncut areas because of the thick anterior capsule. So if you see here that the capsule is already 60% of it is already free floating, but because of the thick fibrotic band in one area, there was an uncut area. So the good thing in fibrotic cataract is that the capsular rhexis, it does not extend because of the fibrosis, and it doesn't let the capsular tear to extend till the equator. So you can gently do that. I used a Vanna's scissor to take out the last portion of the capsule, and then it was very easy to proceed. So similarly, at times, as we all know, that the capsular rhexis margin in FLACS have micro perforations. So at times when you make this was a anxious, uncooperative patient where I could only manage to do capsulotomy. So if you see in this case, we have to be very careful, but because at times you can have an anterior capsular tear in FLACS. So while I was doing cortical aspiration, I suddenly realized that there was an anterior capsular tear, but because I had flap motility sign in my armamentarium, so I kept continuing. I reduced my phaco-parameters. I kept continuing with safe phaco-emulsification technique because I was sure that the flap was everted and fluttering. So I kept continuing phaco-emulsification. You can see while even injection of visco, you can see that the flap was everted and fluttering. So just to see the extension, it had extended till the equator. So my aim was to place the IOL in the bag as due to flap motility sign in my armamentarium, place the IOL in such a way that the haptics are perpendicular in the line of the tear, and it was a toric, so I had no option, so I had placed it and the case was completed. So another thing which we have started doing is, like, as we all know that in anti-VEGF injections there is a pre-existing PCR, so there was a pre-existing PCR in this. So we tell them to do FLACS because you can see the preoperative OCT, there was a PCR in this case. So what we do is we take the advantage of FLACS in two ways. One is by making a small rexus so that I can do an optic capture, and then do a femto delineation. Femto delineation helps in providing me an epinucleus scaffold to the pre-existing PCR. So I'll show you how, and of course you have to follow low IOP phacoemulsification and slow motion phaco as described by Dr. Bob. So I have reduced my settings to 20 and 23 to 26 aspiration flow rate, and this is the case. So capsular rexus was done, and slow motion phaco, low IOP phacoemulsification was continued. You can see the IOP parameters, this was 20. So the advantage is, basically my aim here is to have to do a low IOP phacoemulsification is to because there's a minimal pressure difference between the anterior segment and the posterior segment, so it prevents any pushing back of the nucleus. So you'll see these nuclear pieces will just float in the anterior chamber without being pushed. There is no undue deepening of the anterior chamber, no posterior bulging, and plus femto delineation. Because of femto delineation, you have an epinuclear sheet which provides you a shield to the posterior capsule. So you can see for cortical aspiration, I have retracted my sleeve of the phaco probe because you can differentiate the level of irrigation and aspiration simulating a bimanual IA. Once the epinuclear sheet is separated from all the ends, it is aspirated swiftly, dry aspiration of the remaining cortex is done, and 3-piece IOL is injected into the sulcus with an optic capture, and the case was completed, and patient was 6x6. Always remember to inject triamcinolone to see the absence of vitreous. So I think that's 10 minutes. Okay, so just one or two slides on zonulopathy, because we all know that there's a difficulty in puncturing and tearing the anterior capsule. Then there is a shallow or a very deep AC, then lens is at times decentered, tilted. So there's always a chance of an anterior capsular tear in zonulopathy. So FLACS helps you out in these cases, but you have to remember that there is a greater risk of developing rips if you are using a capsular aiding device like a capsular hook, because of the presence of microperforations. You have to be very careful, as if you use a capsular aiding device, at times you can have an anterior capsular tear. Then micro movements of the lens often leads to irregularities in the capsular rim, and laser energy can be increased if there is a vitreous in AC. So in summary, FLACS is a very useful tool, as it helps you in a fast completion of capsulotomy, that is within 1 second, less nuclear manipulation, less energy dissipated, and it makes surgery safer and easier. Thank you so much.
Thank you, Dr. Tushar. That is excellent. Great idea when not to do. Now, if you have a very wide cataract, to make it under 1 second is so difficult. Yeah. So do you make a rexis smaller so that the first rexis, as they say, otherwise with a manual, that will be as fast as possible before the fluid escapes? Yeah. Because even the Argentinian tear, I have seen in my own cases with a wide cataract, yeah, even in a FLACS, you can get one. Yeah. So how about doing a small rexis? Would that take even lesser time?
So that's very good. I also mentioned, so when you have to reduce it within 1 second, you can do it in few ways. One is by increasing the vertical spot spacing, or by reducing the size of the rexis. So yes, we can do it, and later on after IOL implantation we can increase the size. That's a very good point, sir.
So the advantage of FLACS is actually the rexis, and the disadvantage is also the rexis, because the perforations can really create trouble, as he said, yeah, and sometimes that can extend. Yeah. How do you avoid that? How do you take care of that?
So basically what we usually do is especially for hard cataracts, we make a little larger rexis, so that while you are manipulating the nucleus at times, if you have a small rhexis, it can lead to a rip out because of the manipulations inside the bag. So that is one point that we have to be careful, especially in harder cataracts. Otherwise, if you are making a good large rhexis, the chances of ripping out is less. It is more common in smaller rhexis and when you're manipulating in the bag.
Yeah, so every good thing comes with an added burden also,
Yes,
but finally the surgeon is more important. And if you saw during pulling the fibrotic capsule, he was not doing a rhexis there. He was pulling it in the opposite direction.
Yes,
I think that would be the most important point takeaway. Thanks so much.
Thank you
Dr.
so much,
Tushar.
sir. Thank you.